to another thrilling journey through the territory of lung pathology. I'm Kevin.
And I'm Max. This is a 6 Patterns video, and we're doing our series of the top 25 pearls of pulmonary pathology that you would not want to miss in your practice.
Correct.
We've got a beautiful case for you today. This case comes from a 53-year-old female. And actually, they were nice enough to give you a little bit of clinical history on this case. The patient presents with profound shortness of breath, and she has bilateral ground glass opacities.
You know what? I wonder if this isn't a vape lung.
We'll have to look and see. Bilateral ground glass opacities, 53-year-old female, profound shortness of breath. And you are the lucky pathologist who gets to evaluate this case today.
Surgical lung biopsy, a tray of slides.
So I know how excited you are when you see a tray of slides from a surgical lung biopsy for interstitial lung disease and a long history.
More than one line. You're like,
can I just see the tubular adenoma, please? That'd be fine. I can sign out 10 of those in the time it'll take me just to look at these slides.
Yeah.
Okay, but this case, actually, this is your lucky day.
Yeah.
Because you get this case and you look at the lung and you're like, yes!
No pathology.
There's no pathology here. This is perfect. Because this is a case we can actually sign out, right? Yeah. This is normal. I mean, look at these alveolar walls. This isn't an SIP, it's not LIP, it's not UIP, it's not sarcoid, it's not DIP. Like, this is normal lung parenchyma.
In fact, I would say this lung is preserved so perfectly. I would have thought somebody maybe even inflated it ahead of time.
It was actually processed appropriately.
Right.
And I mean, what pathologist doesn't love to see a little tumor?
Oh my God, it's a tumorlet.
It's a tumorlet. It's so cute.
It's a baby tumor.
We can sit here and we can look at it. We can describe the neuroendocrine morphology of these tumor cells.
Salt and pepper, chromatin, finely dispersed.
We can get some chromogranin, synaptophysin stains on this, CD56. So we can evaluate this. We can say this is normal lung parenchyma. Sign this case out. Normal lung parenchyma.
With an incidental
carcinoid tumorlet. And at this point, you're feeling great, right? You have this big tray, ILD, and yet you're able to handle it within a short period of time. And everything's going great throughout your afternoon until
call from the clinician.
The phone call comes. We all love getting these phone calls.
You think this clinician was upset?
I think this clinician may have been a little bit upset.
Right. Because so the patient's undergone a surgical wedge biopsy. Mm-hmm. I don't know, in today's money, $8,000, something like that.
A lot of money.
You know, pain, because it's done with thoracoscopically, but there's pain, incisions, risks of death. And his patient's still in pain because she's post-surgery, and she's still really short of breath. She's on like high-level oxygen.
She's more short of breath now.
Yeah, and gets back a diagnosis of normal lung.
And you have to remember what the clinician was thinking going into this biopsy. 53-year-old female, profound shortness of breath, bilateral ground glass opacity.
This is an ILD if there
ever was an ILD. The clinician is thinking diffuse alveolar damage, or cryptogenic organizing pneumonia,
or NSIP.
NSIP, eosinophilic pneumonia, acute eosinophilic pneumonia. All of these infiltrative disease processes, cellular NSIP, are going on in this clinician's differential diagnosis. And you come back with a diagnosis of normal?
I don't know how you're going to get out of this.
I mean, the first thing the clinician is going to think is, man, this pathologist doesn't know what they're talking about, because there's no way this is normal. But the reality is that you're partially right. And most of this lung biopsy is completely normal. And it does not have an infiltrative disease process. And really the source of the miscommunication here has nothing to do with the pathologist.
Right.
And nothing to do with the clinician. But it has to do with the radiologist.
Right.
Because what is ground glass opacification anyways?
Increased lung density, through which you can see normal structure. So it'll look white, like a cloud, but you can see structure through the cloud.
And the only way you can see the whiteness is with a contrast to the
darkness.
So at its basic fundamental level, ground glass opacities is what we call in radiology, or they call in radiology, mosaic attenuation, meaning there are some light areas and there are some dark areas.
Right.
So the differential diagnosis for mosaic attenuation includes
pretty narrow.
Includes ground glass opacities, but there's a few other things it includes. Small airways disease,
right,
and vascular abnormalities.
Right.
But 95% of the time, when you see mosaic attenuation, it's ground glass opacities. So radiologists get into the habit, just like we get into the habit of diagnosing a tubular adenoma over and over and over, they get in the habit of seeing mosaic attenuation and saying
patchy ground glass
opacities.
Bilateral patchy ground glass opacities. Now that's because the CT scan in general is done in the inspiratory phase.
Mm-hmm.
When the patient breathes in and the world is expanding in the chest, right? Everything's opened up, right? Air is sucked into the lung.
Exactly.
What they don't do commonly is an expiratory phase where the patient, all right, breathe out and hold your breath, which is really hard if you're short of breath, by the way.
It is.
Breathe out, hold your breath, take another shot, scan it, and now look at the image. Those two contrasts, inspiratory versus expiratory, are part of the evaluation of small airways disease. In things like constrictive bronchiolitis, things like hypersensitivity pneumonitis, where the small airways are injured. So radiologists are tuned into that process frequently, and they can even tell in the inspiratory view whether or not it's more like mosaic attenuation or more like real ground glass.
But if you ask a radiologist who only looks at high-res CT scans of the chest every day, all day, every day of the year, and also reviews a lot of outside CTs, they say, A, it can be pretty difficult in subtle cases to make the distinction, and B, air trapping or mosaic attenuation of constrictive small airways disease is often overcalled ground glass opacifications.
Right.
Very often overcalled as
Now, if you knew that, you could explain it to your irate clinician and saying, look, there is very little pathology visible here. We do have a little tumorlet,
right,
but very little visible pathology. Therefore, I'm justified in calling this normal. The problem is this lung is completely abnormal.
It's highly abnormal.
Now, why is it abnormal, Max? That's the subtle and most difficult challenge.
Well, here we have a pulmonary lobule. It's hard to see where the lobule starts and stops because you can't see the interlobular septum. But I'm scanning through a large amount of pulmonary parenchyma here, and there's something that is absent. And sometimes it's the absence of something that is the most difficult to recognize.
Yeah,
For
scary.
example,
you got to look for stuff that isn't there.
Very difficult to do. So here is a vascular structure.
Artery. Any muscular structure in the lung with blood in the middle of it is an artery.
You don't need a
elastic tissue
stain to know that?
No, you can't see the veins.
Okay.
So they don't have muscles, so you can't even see them.
So what should be right next to this artery?
Bronchial.
A bronchial, and it's missing. It's pruned.
But could it be like a three-dimensional problem with sectioning?
Unlikely.
I mean, if for one.
It's running in parallel with the artery.
But if you missed it in one, count 10 of them. And if you don't find 1 on 10...
Here's 2 more.
Look, so this is where
Here's another one.
The clue we're going to give you. You can count a bunch of arteries in the lung, and there's no bronchial next to it. Here's a beautiful.
Here's a bronchial, but an abnormal bronchial.
Exactly.
The first one we've run across, it's abnormal. And what's abnormal about it? It has extensive
mucus
deposition of mucus, mucostasis within the lumen.
And also back up a little bit and look at the artery next to it. The artery cross-sectional diameter should be roughly the same as the cross-sectional diameter of its adjacent airway.
And so it's ectatic.
It's ectatic.
Bronchioloectasia. So we've just mentioned 2 terms about chronic small airways remodeling. Bronchioloectasia, dilation of the airways, mucostasis, plugging of the airways with mucin. And you can imagine that there's not much airflow moving through this air.
Well, what happened to the airways, Max? I mean, how are we explaining where the airways are missing here?
They've been pruned.
Pruning.
Pruning of the
And you're a guy who knows pruning because you also live in the liver.
Right, and so chronic biliary disease, it's the exact same process in chronic biliary disease. You get pruning of the terminal biliary tree in chronic biliary diseases like primary biliary cholangitis or primary sclerosing cholangitis, and the same thing happens with the airways in the lungs.
And the cause?
So first the pearl. The pearl. With a minimal change biopsy, remember going back to how this all started, we're like, yes, it's a normal biopsy, I can sign it out. Before you go and sign it out, you really have to think about chronic small airways disease, because the most often setting that we see this scenario play out is in the setting of chronic small airways disease.
And it's on the poster.
And it's on the poster under the minimal change
It's
category.
almost the same picture, Max. It's a different case, but the low mag picture here is almost identical to the one on pattern 6 minimal changes.
Exactly. So we have a clue in this biopsy as to what the actual etiology is, and that's in the form of this carcinoid tumorlet.
Yeah.
And in other sections that we're not going to show you, this patient has profound neuroendocrine cell hyperplasia.
Wow.
Middle-aged, female,
Wow.
severe shortness of breath with neuroendocrine cell hyperplasia and carcinoid tumorlets. This is the syndrome DIPNECH.
Wow. Another term.
Diffuse idiopathic neuroendocrine cell hyperplasia. Diffuse idiopathic pulmonary neuroendocrine cell hyperplasia.
I was going to add of the lung to the end of your first one, but you can put the pulmonary in the middle of it.
Well, that's the dip. That's the P of the dip.
The dip.
Right?
Right.
So the pearl with the minimal change biopsy, think chronic small airways disease, and a few other less common things like vascular abnormalities, cystic lung disease.
But look at find your arteries. Look at the blood vessels in the lung, and there should be a bronchiole profile next to, okay, I'll be generous, half of them.
Here's
a cross-section of lung.
And there's 2 arteries right there without one.
Right. So we're already past what's expected for normal. We've lost our small airways.
Exactly. So the circling all the way back around, the end result in this case is that the radiologist overcalled a mosaic attenuation of constrictive bronchiolitis and air trapping as ground glass opacities.
And the reason that happens is when the patient breathes in, even incompletely, the ground glass areas are lung that has stayed in its normal state while parts of the lung have become hyperinflated. So they become dark, and the places that are more normal look like ground glass.
Exactly.
If you do an expiratory film, you accentuate that, and now you have these intensely black areas surrounding these white zones.
Exactly. So I hope you enjoyed this pearl of pulmonary pathology and this 6 patterns video, and like and comment below. Thanks, Kevin.
Thanks, Max.